Welcome to Chapter 1. This is probably more for me than anybody else. So, Chapter 1 has like this hodgepodge of topics, which can sometimes be the most interesting. But what is clinical pharmacology? Anymore, I tell everybody that it's drug development. So, drug development is actually a very broad field. Um, you would need chemistry, biology, um, production techniques like how to mass produce chemicals safely. You need knowledge about regulatory science. So, once again, kind of safety for human consumers. You're going to study these things in animals, but also in humans and clinical trials. So, you also look at post-marketing surveillance, which you know looks at epidemiology, and so really just every topic of science and medicine and chemistry is involved. Often people confuse us, I think, with clinical pharmacists, and basically that's a pharmacist. I'll say non-physician. They're still doctors though, because they have a PharmD. Pharmacists who have done a residency, and they might work in an ICU or something like that. And they're just a pharmacist who has extra training, and they give advice. And often they can even see patients by themselves. Sometimes to evaluate for polypharmacy. So they're very clinical. Clinical pharmacologists, though, can be in any field here. So clinical pharmacologists look at the relationship between the dose and the effect of the drug, also the site of action, the mechanisms of actions, and then we're really focused on, what's the concentration at all times. So how fast was the drug absorbed? How fast did it get distributed around the body? How fast was it cleared? How fast was it broken down? And I have this atomic models here because just like with any model, we know they're inaccurate, but they're still useful. And so we kind of have a model of whatever site of action is present or whatever mechanism of action is working. Model is helpful, but it only tells us so much. And so we have to have an open mind with that. Now, there's tools that a clinical pharmacologist can use, such as randomized control trial, all sorts of chemistry, measuring drug levels in serum, and seeing how that correlates with outcomes. And that's what therapeutic drug monitoring is. Also, we could look at the genetics and look at how fast drugs are cleared. So then the chapter talks about thalidomide. In case you're not aware, thalidomide was a drug used in Europe for morning sickness. So pregnant women took it, and it was actually safe for everybody for nausea, except for women who are pregnant, because infants or fetuses express more genes than humans, and that's because they're having to grow. They have to grow more than just normal humans do, I guess. More things are being developed. So a lot of infants didn't have limbs, and this is called phocomelia. But anyway, why did that affect the U.S.? It was actually never approved here in the U.S., but it was such a high-profile topic that it caused this amendment, essentially giving a lot of power to the FDA. And because of that, they got a lot of funding, and they set up all these centers, and a lot of tenets that are used in current drug safety were developed back then. So basically, they decided we need clear goals of treatment, and that actually is so true. So often we just, maybe ask a patient if they feel better. Well, that can be very subjective, and so you're even helping the patient more if you can actually tell the patient, hey, these are our goals of therapy. But that takes a lot of conversation and a partnership, which is hard to establish because it takes time. Anyway, I feel a lot of people don't want to teach the patients anything because then the patients will have good questions, which are appropriately so, which just means then they have to talk more and they'll get more behind. And so it's often easiest to just not really tell the patients why they're taking what they're taking or things like that. Okay, they also decided to avoid polypharmacy, so that makes sense. But so often that's what happens. We just start a medicine and it's just on there for life. A good rule of thumb is one medicine per decade of life. So, by the time you're 50, you're taking like 5 medicines every day. Do you still need those? And then also these guys figured that we don't really prioritize looking into the causes of adverse events. And that's because mechanisms can be hard to nail down. They also found that there's a general ignorance of pharmacologic principles, and most adverse reactions are dose-related. So even though this is very sensational, the thalidomide, and it was very specific, most adverse reactions, aren't as sensational, and they occur with existing drugs. Then the chapter talked about how medical professionals, perhaps surprisingly, have a very haphazard teaching or haphazard training. And a lot of med schools have maybe 1 or 2 classes in 4 years on pharmacology. I guess I don't know exactly why that is. There's just so much, and you're really only interested in the drugs you give. And I'm not exactly sure why, but it is a little haphazard, meaning whatever your friend happens to know or whatever your mentor happens to know. A good example of this was Singular. Singular was FDA approved in 1998, and I think the label got updated a year later, but because that wasn't really the focus, no one knew about the label being updated. Like 10 years later, in 2008, and they put suicide as a potential adverse event, but no one even knew about that. And so in 2021, the FDA actually puts the suicide in a black box. They said specifically because even though it had been on the label for 10 years, no one knew about it, meaning doctors, patients, and nurses and pharmacists. There's a lot of things to read. So very haphazard, and learning. There's an overview of drug development. So just some big things. Basically, preclinical means like animal, essentially. And so in animal studies, you kind of have to prove that it's safe. So you got to test the drug in 2 animals, 2 species, prior to testing it in humans. And these have to be done in what's called good lab practice, GLP lab settings, just to ensure there is integrity in those trials. So you're going to establish the pharmacokinetics, like how does the drug work, and how is the drug handled in animals first, and then once you're ready for that, you're going to do an IND, which is just an IND is an investigational new drug application. So basically you have to submit for permission to try a new compound in humans. That'll start with phase 1, phase 2, and then NDA, new drug application, that's to file to get the drug approved for public use. Now, there's also, I guess, these dotted lines, they don't say what they're here for, but you do want to talk to the FDA in between like phase 2 and phase 3. I'm not sure if it's like an absolute law, but you would want to anyway, just to make sure they're going to be on board with your endpoints and all that. So that's kind of the overview. So then it talks about metabolites and clearance. So this will just give you an idea of things that come up. So one of the first antibiotics was something called Prontosil, and that was basically a red dye used in like textiles and fabrics. And they found that sure enough, you could give these to mice, and they would be protected against strep. The mice would turn pink, but maybe that's worth it. Well, come to find out, the chemical was actually getting broken down in the mice, and this one, I don't even know how to say it, but sulfanilamide was actually what was active, and this one is not colored. So you could just give this, but that's an example of how we discover these things. Like, we don't know what the body does to the drug and what's active and what's not active, and getting your skin turned pink, maybe that's an adverse event, unless you wanted it. But my guess is it's going to cause inflammation as well. And anyway, here's another example. Apparently, it's super famous. Seldane. So Seldane was a drug that was a non-sedating antihistamine. It's one of the first. So basically, everyone likes Benadryl because it can help them sleep and maybe treat a cold, but no one likes Benadryl. That makes them drowsy. So Seldane basically was an antihistamine like Benadryl, but it was non-sedating. So everyone loved that, and it was one of the first like that. So it's very popular, very widely used. But then rarely people would have torsades de pointes, which is basically a arrhythmia, like a cardiac malfunction. We'll say that just the electric signal in the heart isn't transmitted correctly. Well, come to find out, this was the active form, the fexofenadine, which was terfenadine carboxylate. There's only just a very small change, so we could just give that instead, and you could completely avoid the cardiac arrhythmias. The issues, I think that this was known at the time, unlike the red dye example. The issue is that fexofenadine isn't absorbed by the gut, so we call that bioavailable if it's absorbed by the gut and not cleared immediately by the liver. So basically, bioavailability being 10% or 10 to 30% means, as much as 90% isn't even absorbed by the gut. And that's why they had been giving terfenadine. So that could be a deal breaker. But anymore, Allegra is given, it's just given with this super large pill. And you can compare that to like Claritin or Zyrtec, where the pill is very tiny. But 90% of the drug you're just going to excrete, like as if it was fiber, like in the feces. So sometimes, even though the metabolite's active, you were giving it as terfenadine just to make it be absorbed. So there's all these stories and exceptions, and you can tell how this would be super hard to regulate every single scenario. Then pharmacogenetics, this plays a role because, for instance, tamoxifen, it's an anti-cancer drug given for like breast cancer. It's an estrogen in the estrogen family, and actually what's active is the endoxifen. So most of these large arrows is the larger path of breakdown or metabolism. And if you happen to have these genetics, these isoforms, so that specific gene in your liver, you'll favor this, and most people do. But some people have, just like they have different eye color, they have different genes, different shapes of genes in their liver. So some people actually go through this smaller path, going to the right, immediately to the right. So some people are going to have less, production of the endoxifen, and that they might actually just stay at this 4-hydroxytamoxifen, which means they're not going to get the benefit. Well, that would be a big deal, right, for cancer. So, should we do genetic testing prior to treatment? It's tough to say whether that's worth doing, because that's going to be like a 4-week test at least before you even get that back. That's my dog snoring. Sorry. But it's just very controversial in that it's not clear that it's worth it because it's not like tamoxifen is 100% effective anyway. And it talks a lot about clearance. I think this is the last slide. Clearance, you'll always read a lot about it. Basically, I think the best thing to remember is the therapeutic window of a lot of drugs isn't that small. So maybe one equation might be, 10 or 15% better at predicting the actual clearance, but it's not like 10 to 15% of a change in the concentration really matters that much. And if it does, because the therapeutic window is small, then you're probably um, testing for that drug anyway, such as like with Coumadin, where you do like a daily or weekly test to see how therapeutic it is. So if it was that sensitive of a drug, you would be testing the lab levels anyway. So that's why I think not a lot of people care too much about the clearance, but you'll read a lot about it. So Cockcroft Galt is widespreadly is used, definitely used in the hospital and even in a lot of drug studies because it's easy. It's a lot of guidelines based on it, and so it's based on creatinine. I think the best way to explain that is creatinine is naturally broken down by the body, so it's a breakdown product of muscle. So everyone's always producing creatinine. It's your body's making and breaking down muscle. So just imagine like a constant stream. Well, if you don't have much muscle, that stream is going to be small. And then the kidneys are just going to clear it because it's not useful anymore. Well, that can essentially tell you how fast the kidney is clearing, the blood. Except one issue is the kidney doesn't completely leave creatinine alone. There is a little bit of absorption and secretion. So some chemicals might be better, such as these inulin and cystatin, but they could be more expensive. I think cystatin is naturally occurring, but inulin, I think you have to actually inject. No one actually does this, even though we talk about it all the time. But they're technically more accurate. Like I said, we just don't care. But what you do need to know about creatinine is that, imagine it's like a reservoir. So I said creatinine is like water height in a reservoir, and kidney is the drain. So if you've got this flow of water, and then you've got a reservoir, and then you've got a dam, and it's letting water out slowly. Well, measuring the serum creatinine is like looking at the reservoir height. How much water is in that is behind the dam. So if I, let's say, ruin the drainage pathway or shut the dam up, well, it's going to be a while until the level rises, and then you'll know you're in kidney failure. So it doesn't show, acute changes because we have to wait for the creatinine to accumulate, which is from the muscle breakdown. Now, other issues, what if you're a person who just doesn't have a lot of muscle? So the creatinine is going to be low, which means it looks like your kidneys are working great, right? But in reality, maybe you're just malnourished and you don't even have muscle. So you can see, aside from being inaccurate, it can also be misleading, I guess, based on the assumptions. But anyway, so creatinine clearance is going to be based on age and weight and the creatinine level. And the creatinine, well, so the age and weight is going to be kind of a surrogate for how much muscle mass you have. And women, because they have less, you should decrease this. But, age and weight aren't the only things that affect muscle mass. So, like, is this person a bodybuilder, right? Does this person just barely work out? Because if they're working out, the day before, now they have more creatinine. So are they in kidney failure, or were they just working out, right? And that can get complicated because people who do have a lot of muscle breakdown, they're also losing myoglobin. So myoglobin can kind of clog the kidneys, and then you can have rhabdomyolysis. So, and that's which is really just kidney failure. So in that setting, people who work out too much, they have their kidneys shut down and their creatinine's high, but that's why. So, all right, so this is slightly more accurate than MDRD, apparently, but and often I think the hospital or just the lab will report this. They'll say if African American, modified by this factor. So This one's going to take age and race and gender in, but it doesn't have weight, so that's interesting. And then for kids, for peds, this is actually more accurate, where you've got L is in height for length. Basically, that's going to be your surrogate for muscle. And then K is sort of like this, just constant based on age. So you really look at height and age and creatinine. So everything is basically muscle mass and creatinine. That's where we're at. End of chapter 1.